Esteemed members, good evening and welcome to today's session. Just to confirm, if you can hear me, kindly send a message on the chat and let us know where you're joining us from, which branch of PSK. See a message from Dr. Patrick. All right, thank you. Dr. Rashid from Webuye, thank you. Dr. Joshua, Dr. Ken from Nyanza branch, thank you for your confirmation. See Dr. Onesmus from Baringo, welcome. Okay, just as we wait for our colleagues to start, I'd like to request you to kindly visit the PPB portal and subscribe to this event. You can use the keyword pills or beyond pushing the pills, and you should be able to find the event on the PPB portal. And also just a reminder that once you subscribe, we'll be able to get the tokens from PPB and be able to send to you on time. So the earlier we get the subscriptions from you, the earlier we're able to send it. So you're encouraged to subscribe early so that you get the points. Karibuni for those who are joining us. I see members from Kirinyaga, Kitui, Nairobi, Nakuru, karibuni sana, Uasin Gishu. And for those who joined us, we're just subscribing to the event on the PPB portal. You can use the keyword pills or beyond pushing the pills. You should be able to find it easily. Okay, I think we'll get started now. Once again, welcome to today's webinar. And this webinar is on Beyond Pushing Pills, Saving Lives, Smart TB Pharmaceutical Management. And this event is proudly supported by MSH and the Tamatisha TB program. For this session, we'll be having a speaker from the National Tuberculosis, Leprosy and Lung Disease Program. That is Dr. Ernest Mbaye, who's the Senior Deputy Director of Pharmaceutical Services. A reminder again, if you've not, ensure that you subscribe to the event on the PPV portal. And ground rules, you'll be muted during the entire course of this webinar. So if you have any questions, kindly use the Q&A tab so that we'll be able to track your questions and they'll be responded to by the speaker at the end of the session. This session is also being recorded and will be made available on PSK's YouTube page. So at this point, I'd like to welcome Dr. Joseph Mukoko from MSH, who will be giving some opening remarks. Then thereafter, we have our presenter, Dr. Ernest, taking over. Dr. Joseph, if you can hear me.
Yes, good evening, everyone. I hope you can hear me.
Yes, we can.
Okay. So good evening, everyone, and glad to be able to join all of you this evening. My name is Joseph Mukoko from Management Sciences for Health, MSH. And through this, we are partnering with the PSK and also the ministry through the National TB program to really bring you this series and recognizing that TB is one of those areas that I think very many pharmacists have probably not been very much involved in. And as we do this, of course, we do recognize this is support from the US government, and we do this supporting the ministry, but working through a consortium of other partners like CHS Kenya and others. And a lot of the support is to the ministry directly and also to the various counties, really trying to see how we can address TB control. And as MSH, one of the key things we are very keen is to strengthen the pharmaceutical systems and more specific improving access and also issues to do with the use of the various TB commodities. So today is just one of those series of sessions that we are going to be having. And why this was crucial is we've recognized that as we do this, there are a lot of things that are happening in the TB space that pharmacists should really be interested in and should really take charge. And we are looking at this beyond just the public sector, faith-based and private sector. And today, of course, we are very privileged to have with us Dr. Ernest Mbae, who is a Senior Deputy Director, Pharmaceutical Services at the TB program within the Ministry of Health. So, karibu sana, Dr. Mbae. I think this is just one of those, and I know it's a there's a lot of information that could be shared, but I think let's just start off this and really looking forward to getting a lot of interactions from the rest of the membership. So, asanteni sana, and really looking forward to the interaction. Thanks.
Thank you, everyone.
You can go ahead, Dr. Mbae, karibu.
Okay, thank you. Thank you, Dr. Mkoko. Thank you, Dr. Hezron. As Dr. Mkoko said, my name is Dr. Ernest Mbae. I am happy to be here, and thank you. I want to thank you all for lending me your ear for the next 1 hour or so as I try to bring you into the TB world, show you what are some analysis we can do in the TB world. And as Dr. Mkoko suggested, where you can draw in and bring you more into the management of TB. So I'll just give me a minute to share my slides. Dr. Mkoko, Dr. Ezra, can confirm my slides are visible?
Yes.
Yes.
Okay, thank you. Thank you. So I'll just move quickly to the outline. I will, as most of you are pharmacists, I assume just like me, you probably prefer the chemistry to the pathology. So I will very quickly take you through the pathology so that we know why we are treating TB, why TB is an issue, why should we give it special focus, why are we having a special public health program specifically dealing with TB. So I'll talk a bit about the introduction, how TB develop, we get infected with TB, how it devolves into TB disease, and then a bit the Kenyan situation. I'll talk about the global situation, incidence, and then also the Kenyan situation. Then I'll talk about the strategies that we have for managing TB. So starting with the prevention, then the treatment, and then for the DSTB, and also for the worst case scenarios that we usually try to avoid as much as possible, treatment of the drug resistance TB. So TB is called tuberculosis. For those of you who are interested in history, it's actually historically it used to be called consumption. It is a disease that is caused it's an infectious disease caused by Mycobacterium, tuberculosis bacilli. Human beings tend to be the only known reservoirs for Mycobacterium tuberculosis, but it is a part of a complex, so Mycobacterium complex that also includes Mycobacterium bovis, Mycobacterium africana, macroti, and caneti. But the main one of issue is usually Mycobacterium tuberculosis. But we also have other mycobacteria that are available and actually can cause infections. We have the non-tuberculosis Mycobacterium, commonly known as NTM or MOT. These are usually found in soil, water, or sometimes in pasteurized milk products. And of course, we have Mycobacterium leprae that is known to cause leprosy. In terms of how TB is transmitted, this is through droplets from person to person. So as you speak, as you cough, as you sneeze, And as you can see from that, my presentation, depending on the form of transmission, if it's talking just transmitting between 0 to 200 bacilli, if you're coughing, about 3,500. Sneezing, you're really pushing out the bacilli out there. So it's one of the etiquettes. I think we learned a lot during COVID about how to sneeze, how to cough. This is one way of also preventing transmission of TB. We also have other less frequent modes of transmission through ingestion, like for Mycobacterium bovis through milk, because this is found in cows. You can get it through skin, inoculation, and very rare, it can be transmitted from mother to child in the womb. So the common signs of symptoms of TB, and this includes both the drug-resistant TB and drug-sensitive TB. I think for adults, the most common are cough of any duration, fever, drenching night sweats, unexpected weight loss, where we have a BMI of less than 18.5 for adults, or Z-score of less than -2 for children. When we have chest pain and difficulty in breathing. For children, it's actually much more difficult to diagnose because in addition to now the adult symptoms, which are not as prominent, also, we have, especially for children under 5 years, we have wheezing. If you see the child is failing to thrive, they're not gaining weight as they're not meeting their milestones, the expected milestones as they grow, because at that age, children should be gaining weight significantly quickly. When we have reduced playfulness with the children, or when you see they're lethargic or irritable. So those all form the initial common signs and symptoms where you're usually encouraged to go for TB screening. We also have extrapulmonary symptoms, that is like swollen lymph nodes for TB lymphadenitis, chronic back pain for the spinal TB, severe headaches and confusion for TB meningitis. So some of these signs and symptoms are quite common from not just TB, from most other upper respiratory tract infections. So it's always good to confirm the history of the patient. They've been in contact with a TB patient or somebody with a chronic cough, because that can aid in actually zeroing in on TB diagnosis. So anybody can get TB, as I said, and it's a point to point. So even in the matatu, somebody coughs, somebody sneezes, that you become a potential case of getting TB. And as pharmacists in there, and not just pharmacists, but all of us in the healthcare system, I mean, in the healthcare worker fraternity, we know we tend to be much more exposed to getting TB. You're always dealing with the TB patient. I mean, patients coughing, people with upper respiratory tract infections who have signs and symptoms that could be TB. So we always find ourselves being exposed to TB. So, but some people have a higher risk. That's, as I said, as the healthcare workers, we have a higher risk. People who've had contact with somebody who has a TB, of course, that means you have a higher risk of getting TB, including now the household contacts who have up to 7 times the chance of getting TB from somebody out in the street. Then when we have high prevalence of TB within a population, of course, the higher the more people have TB, the more likely that you are going to get TB. And then the type of TB, some like the pulmonary TB is more infectious. As I said, TB is spread through point-to-point droplets. So if you have a pulmonary infection, you're probably going to be coughing and you're more likely to transmit the TB. So the natural history of TB infection, and this plays a very important role in our management interventions. So on exposure to TB, 70 to 90% of us luckily will not get TB. 10 to 30% of us who will get TB based, and then of those 10 to 30, 90% will actually not develop active TB. They will get TB infection, what we used to call latent TB infection. These days, WHO changed the terminologies. It is actually called TB infection. So 90% of these will actually not get TB, but they will have the infection because, as you know, the TB, the Mycobacterium bacteria, bacilli, it's quite difficult to kill. The moment it infects your lungs, you have the natural body reaction, the macrophages, most of the time, it doesn't clear completely. It gets hidden in the granuloma. Remember, if you remember your pathology for microbiology, the GON focus, where you have the macrophages surrounding the mycobacterium bacilli, which is still active. I mean, it goes to dormancy, but it can still re-emerge at a later date. So most of the people who are infected actually fall into that phase where the immune response, the body immune response is enough to contain but not eliminate the bacilli. For the 10% who will actually have active TB, of those, 5% will actually develop within the first 2 years of exposure to TB, and then 5% will get years later. And again, this is actually due to the activity of the mycobacterium bacilli and the immune response. So for those whose immune response is not as strong, then that's what they'll get within the 2 years. And those ones who have a stronger immune response, that fight, eventually you'll end up losing. 5% will end up losing that fight, and they will have active disease a couple of years later. Of those ones who develop active TB, if you get treated, if you get access to, if you are diagnosed in good time and you get access to medicines in good time, you're actually going to get cured. There are those, unfortunately, those who do not get treated, 50% of them will die in the first 5 years. Then 25% will recover, and then the other 25% will remain sick. So our interventions that we have in terms of TB management actually follows this natural history. So we'll start with we have to address the ones who have the TB infection, who do not have active disease, but they do have the TB bacilli in their system in dormant stage. So we have to have an intervention there. And of course, the more common one, the ones who have active disease, we are intervening by getting you the medicines and getting you treated. The untreated ones are the ones who tend to be a challenge. And I think, unfortunately, some of us healthcare workers tend to fall among this group, where either through stigma or through an inability to want to have your status known, we refuse to get the TB treated. And then I am sure some of you may have, myself included, have actually had colleagues who've had TB, who've refused to be treated, who've refused to actually mention their situation because of fear of stigma. So we also have intervention measures to try and address this. And this I will not be covering in today's presentation, but this is something that we also have intervention to try and reduce stigma. And also for those ones who are not aware or are not missed, the cases that are missed, we actually go outreaches to get those cases so that we ensure that anybody who's infected actually gets access to the medicines, because the medicines are available. And as I said, TB is treatable and can be cured when you have access to the medicines in good time. So risk factors for how we are going to progress to active disease for those who've been exposed, for the 5% who've been, for the 5 to 10%, for the 10% who moved to active, and for the other 90 who initially had latent TB, had TB infection, how it moves to active disease. This happens for those who have been recently infected, of course, because you've been recently infected with TB, yet the TB bacillus has not yet progressed into a dormancy, so it is still actively developing, dividing. So they are more likely to get the infection. It's more likely, the exposure is more likely to develop into active disease if you are poorly treated for a previous diagnosed TB case. So if you are not given the right medicines, if you do not take medicines in the right for the correct duration, then there's a likelihood that, as in some subsequent slides I will show you, you'll end up actually having your maybe clearing the actively dividing bacilli, but the dormant ones are actually left, and the moment you withdraw, you don't get sufficient the full complement of your regimen. Then you have the dormant cell bacilli actually reemerging, and you getting infected, getting back active TB disease. The others are children and elderly. Of course, it's obvious these are the ones who have the immune system. The children, their immune system is not as active, as well developed. And for the elderly, unfortunately, we are reaching the end of the cycle. The immune system is degrading. So they are more likely also to get active disease on an exposure. And then all those conditions that have weakened the immune system. Remember, there's that fight that is ongoing between the bacilli and your immune system. And as I said, the bacilli is not completely eliminated, it is just contained. So when you have your immune system compromised, then they're definitely going to have your dormant cells now emerging and going into active disease. So you have like the HIV infection, cancer, diabetes, substance abuse, any medical condition that requires treatment on corticosteroids, silicosis that actually weaken the lungs, organ transplant, because organ transplant is usually, you're going to take immunosuppressant medication so to avoid organ rejection. That ends up blowing up, lowering your immune system, of course, making you more vulnerable to the dormant bacilli reemerging. Then we have those with severe kidney disease or low body weight. So now I need to talk a bit about epidemiology, because as I said, TB is a respiratory tract infection. Why are we giving it so much attention? It's just like a normal common cold. Go take your antibiotic for 1 week and take a lot of fluids and you should be okay. Why don't we do that? So part of the reason is because of, if you look globally, TB, 10.8 million people died. Were infected with TB. That is 2024. Sorry, 2023. This is a WHO 2024 report, but it uses the 2023 data. And of this, in addition to this, we had 1.25 deaths. And this makes TB the leading cause of from a single infectious condition. It used to be COVID. It used to be second to COVID in 2019, in 2020, 2022, but it has reclaimed its top position. So this is one of the reasons why it is a leading killer. It is a leading killer from a single infectious disease, and that is why we have to give it special attention. So of the deaths, 1.25, we had 161 of these were actually people living with HIV. 161,000 people living with HIV. In addition, drug resistance TB continues to be a problem because we are still reporting drug resistant cases, and these are more difficult to treat. And as I discuss further, you will see the complications and the challenges that continue that are part of management of drug resistant TB. Going into the Kenyan situation, this is the burden from Kenya. This is again using the same WHO 2024 report. This is working with the 2023 data. So according to the WHO, our incidence of TB is 124,000 cases. So we are expected to be getting around 124,000 cases. Unfortunately, in 2023, we're only able to report 94,653. So from a quick math, we missed out 29,347 cases. So essentially, in as much as we have those 94,000, there are about 30,000 people who are going out there, who are walking out there, who have TB but have not yet been diagnosed and have not been put on treatment. So there are those untreated number that I said that some will die, some will actually end up, and they'll also continue spreading TB to the general public. So this translates to a treatment coverage of about 77%. So we still have, in as much as we've made some steps over the years, we still have some ground to break, because from 2015, between 2015 and 2023, we've actually reduced our TB incidence by 41%. So that is very good, but that coverage of 77% still shows that we still have some ground to cover to ensure that we move to 100% so that our incidence actually goes lower. In terms of TB mortality, in 2023, we lost 23,500. Of these, 8,000 were PLHIVs. Again, we've made steps between 2015 and now, and 2023, where we had a reduction in death by 60%. Still, any death is not acceptable. So our aim is to continue in our our aim is to ensure that we continue getting these cases that we are losing, these lost cases, because these are the ones that are contributing to our TB mortality, and also managing our comorbidities, either whether we be it HIV, diabetes. So, and we've taken quite a number of steps. So we are doing integration of our TB services, so that we are doing integrated services between TB and HIV, integrated services between TB and other diabetes, for example, so that when you're managing TB, you're not managing TB in isolation, but you're actually managing TB in the bigger picture, knowing that this is an individual who has other conditions that also have to be managed together. So moving to the updated data for 2024. So in 2024, we reported a slightly higher number than in 2023. So that was 96,865 cases. Of these, 12,557 were children. And unfortunately, about 751 were drug-resistant cases. As I said, and as you see, management of drug resistance tends to be a bit complicated and challenging, and it requires a bit more effort on our side and cost more. So of the cases that were detected, about 76% were detected and managed in the public, and then 23% were detected in the private sector. Shows that the private sector also has a role to play in management of TB. So in terms of distribution of TB for 2024, I wanted to show this slide to just indicate, to see that a worrying trend. So first, you can see actually the TB affects more the age group affected the most are between 20 and 55. This tends to be our most productive ages when we are actually getting TB. Our people are getting infected with TB, reducing their productivity. And also you can see the male are actually more likely to be affected than females in terms of TB. So all these are reasons why we need to start. We need to have TB being treated. Why TB is treated as a special program. Then I mentioned the management strategies, so let's start quickly go through prevention of TB. Now, for the 90% who get infected but only get TB infection, do not progress into active TB. So the rationale is very simple. We already know you've been infected, you are healthy, you're not exhibiting any signs and symptoms of TB, though you do have the TB bacilli in you. So what we want to do is clear that bacilli before something happens in the future that may end up lowering your immune system and lead to progression into active TB disease. This tends to be cheaper, and studies have shown that actually for every dollar that is invested in TB prevention, we save $4 to $39 in terms of the man hours that we would have been lost should that individual have gotten sick. So that is why TB prevention is actually one of the key cornerstones in actually managing TB. So why do we do that? As I said, it's to reduce the risk of progression of TB infection into active TB, and this is by killing the dormant cells that have been contained within the granuloma, the gone focus. That is, you kill that, then there is no chance of that progressing to active TB disease. So it reduces morbidity, because one of the signs and symptoms of TB is unexplained loss of weight. So these tends to end up can lead to hospitalization of the patient. So we are reducing morbidity of the patient by ensuring that active disease doesn't progress to active disease. I mentioned cost. It saves costs because it is cheaper to prevent than it is to treat. You'll see when I talk about the regimens and the duration of the regimens. And then since the bacteria is actually in dormancy, it is in a dormant state, there's less likelihood to develop resistance. Therefore, you do not have to use the full battery of drugs that are usually recommended for management of TB. Again, I'll talk a bit more about this in some subsequent slides, and you'll understand why. So who are eligible for TPT? These are individuals who are already at risk of getting TB, either or having the immune system compromised, so like the PLHIVs, then the prisoners and staff working in prison settings, these tend to be high infection areas because you have crowded area. It's a crowded area, so you're having a lot of transmission of TB. Healthcare workers, because of constant contact with TB patients, then all contacts of TB patients, whether they are DR or DR-TB. Bacteriologically confirmed patients. These are the patients who have actually shown they have the TB bacilli through a lab test. So if you are a contact, then that means the people who live with you are more likely to get access. I mean, are more likely to be exposed to TB as you cough, as you sneeze. And then the clinically risk groups, these are the ones I mentioned again, the patients who are on immunosuppressants, who have a reduced immunity, so they are more likely to develop. And these are the ones who actually recommended that they be put on TPT, on TB preventive therapy. So very important, we need to rule out the TB disease before we give TPT medicines, because as I said, we are not giving the full battery of drugs required for the regimen, because we are dealing with dormant bacilli. But should you give the TPT regimens for somebody with active TB disease, you're actually exposing them to risk of development of drug resistance TB, where you actually make a simple process, you actually make it much more complicated. So you need to rule out active TB. Then you need to initiate with the right appropriate TPT regimen. There are different regimens based on the age, the weight, and the condition of the patient. Then any signs and symptoms of liver disease, yellowness, abdominal pain should be ruled out before initiation, because you do not put TPT on any person who has liver disease. Then we also need to assess the comorbidities, so to make sure that whatever the drug we're giving is actually not complicating the situation, because our aim is to do no harm, not to add to the complications that the client is already having. The regimens that are available, we have 3 regimens. The first regimen is a combination of rifampicin and isoniazid. This is taken once a week for 3 months. This is the one that is currently recommended for all our HIV negative and positive populations, adults. And there was a new development in the WHO guideline where actually now the same is actually recommended for children and up to 1 year and above. So essentially all our TPT contacts now, all our TPT contacts will actually be eligible to 3HP. These are guidelines that is ongoing. The revision of the guidelines are ongoing, and the targeted rollout of this is going to be January 2026. And when the program has finalized the processes of rolling this out, I will be making I will be having another webinar just specifically to focus on that in the future. So when we are ready, so that also, I realize sometimes when some of these regimens are being rolled out, us as pharmacists are actually left out. We do not know. We end up only becoming aware when the regimens, especially for those of us in the public sector, we only become aware when the drugs are brought to our county stores, to our sub-county stores. That's when we realize that, wait, there's a new regimen. So I will also be working with the TPT contact person to have a similar webinar done when we are ready to start having trainings of all the healthcare workers. So the other regimen that is in use is a combination of rifampicin and isoniazid, and this is taken daily for 3 months, and it is taken for our HIV negative children. Anybody below, and in TB world, anybody below 15 is actually a child. So this is taken by the children, but this now will actually be replaced by the child-friendly 3HP regimens that will be coming. That will be rolled out in from January next year. And then there's 6 months of isoniazid. This is taken again daily. And this is taken by anyone who for one reason or the other is not able to take either the rifampicin or the rifampicin regimen, and also for pregnant women, because rifampicin and rifampicin are usually not indicated for pregnant and lactating women. So This is also a new development again from the WHO, where we're also working towards having TB preventive therapy also for our DRTB contacts. So we have 6 months of levofloxacin. This is taken once daily, and this is going to be for all contacts of patients. Contacts of patients with MDR-RR. This is a multi-drug resistant TB, and multi-drug resistant TB is any TB that is resistant to isoniazid and rifampicin. So that is MDR-RR. Then also for rifampicin resistant TB, so they're usually classified clumped together, MDR-RR/RR, but who are fluoroquinolone sensitive. So what we do before, as part of drug sensitivity testing, as you are giving the regimen, we actually do a drug sensitivity test. So before you give levofloxacin to the contacts, we have to confirm that patient actually, that resistance pattern of MDR-RR is sensitive to fluoroquinolone. Otherwise, we'll be making the situation worse because we'll be giving TPT to a contact of a patient who's already resistant to the fluoroquinolone. So that will not actually be doing will not be actually helping anything. And that will be a pre-XDR patient. So the other regimen is 6 months of isoniazid, similar to the 6 months that's taken for the DSTB contacts. And this is among the contacts of any MDR, any DRTB patient who is isoniazid susceptible, other than the RR, because the rifampicin resistant patient will take levofloxacin. So if you have any resistance to any of the other TB medicines, other than isoniazid, of course, so if you are resistant to ethambutol pyrazinamide, then you will be, the contacts of that patient will take 6 months of isoniazid. And then finally is 4 months of rifampicin, again taken once daily for 4 months. And these are for any contacts of an index case whose pattern is isoniazid resistant, but has been shown to be sensitive to rifampicin. So during the drug sensitivity testing, that isolate, the mycobacterium isolate, was shown to actually be sensitive to rifampicin. So the contacts of that patient will be given 4 months of rifampicin. Again, these have not yet been rolled out. So we are in the process of reviewing the guidelines, just like I mentioned, the pediatric 3HP. So when we have the full, when we are ready to roll it out, because the plan, again, just like the 3HP, the plan is to roll out specifically for the 6 months of levofloxacin, 6 months of isoniazid. The plan is to roll this out from January next year. When we are ready, when we have all the commodities in place, we'll actually be having sensitization workshops and sensitization webinars. So we will be involving you as part of the healthcare workers will be sensitive. So for the 4 months of rifampicin, I think we are yet to, still a bit controversial. We are still worried about rifampicin because rifampicin tends to be our mainstay in treatment. You'll see in some subsequent slides. So this has not yet been agreed on, but though this is still a WHO recommendation, but this has not yet been agreed on whether we will be moving to this. But again, when you do, we will be having sensitizations, and we will make a point of ensuring that we also do the same in such fora. So for treatment, our goal, just like for TPT, is to ensure, you don't go into active disease. But the moment you've gone into active disease, our goal is to make sure that your interruption in your daily activities are minimal. So it's to restore back your quality of life and give you back your productivity as soon as possible. The other one is to prevent death, of course, and also any complications that arise from activity, because we do tend to have quite a number of complications. The other one is to prevent relapse. So we have to make sure that we treat you appropriately with the appropriate medicines to ensure that you do not have a recurrence, because we did not clear out all the bacteria, or the bacilli, sorry, that infected you. And then, of course, to reduce transmission, we don't want you to go out there and start spreading to other people, because that increases our incidence rate. And then, just as important, is to prevent development of and transition of drug resistance. So our rationale. I touched on this earlier. When on infection, you're going to get actively dividing bacilli. But then as the body immune response combats the bacilli infection, you end up, your cells move more into a dormancy stage. So you have to have in the medicines that you're going to, the medicines that you're going to use to treat your infection has to have ability first to be able to actively kill the rapidly multiplying bacilli, the ones that have just infected you as they are rapidly dividing. They should have some bactericidal activity so that it's able to kill those bacilli. In addition, after it's killed those bacilli, it should also have the ability to kill the persistent, the ones that have moved into dormancy, so that we do not have a relapse. So the medicine has to have both of those capabilities. And you realize it's not possible to have one specific medicine that does all that. And that part of the reason why we end up having combination therapy, where you have multiple drugs, so that one does bactericidal activity, has more sterilizing activity. And also that's why you find that our regimen, our treatment has an initiation phase where we are treating, or rather, we are killing the rapidly multiplying bacilli. That is, we are focusing more on the bactericidal activity. Then after that, we have a continuation phase where we are sterilizing, so that we are killing the ones that were able to hide, in the gone focus, in the granulomas. So we are able to kill that. And that's why if we find our regimens need to take longer. The continuation phase is actually longer, but also we have fewer drugs, because we do not need all the regimens all the drugs components for the sterilizing component. I think I touched on this. Yes, I've mentioned why we have to have the fixed dose combinations, and why we have the intensive and we have the continuation, and why our treatment tends to be very long. Upper respiratory tract infections, 5 to 7 days. Ours for TB, we end up treating for up to 6 months. Actually, for the DRTB goes even up to 18 months, but we'll touch on that later. So that is why, because of that, because we have to allow for initial time for the bactericidal activity, for the rapidly multiplying bacilli to be killed, and then now sterilizing, so that for the ones that have gone into dormancy, the ones that are less not active, to actually also be cleared out. So another thing that is very important, drug sensitivity has to be done, so that these advises on the choice of regimen that you're going to use. Because if your drug is not susceptible to rifampicin, for example, if the bacilli, the isolate, is not susceptible to rifampicin, why give rifampicin? Then you tailor the regimen based on the drug sensitivity, the drug sensitivity test. So again, I touched on this, that you're using 4 effective drugs, so that you need 4 effective drugs at to clear the rapidly dividing bacilli, and then 2 to 3 drugs to deal with the continuation, to actually sterilize, to get rid of the bacilli that have moved into the dormancy. If improper drug sensitivity tests are not done, there's a high risk of actually having monotherapy. And I will talk more when I'm talking about the management of treatment of drug resistance. I will talk about the dangers and the consequences of monotherapy, because this can inadvertently lead to drug resistance and amplification of drug resistance. And then, very, very important, we should never add a single drug to a failing regimen. The recommendation is change regimens, other than change to a recommended regimen. Do not work if it is working. If it has failed, do not, because this just makes the situation worse. Then compliance is key. As I said, our regimens tend to be quite long, taking up to 6 months, some up to 18 months, as I said, for the DRTB. So for you to have a treatment success, you have to comply. And that's why we have direct observed therapy. We have treatment supporters who actually ensure that our TB patients are taking, our TB clients are taking medicine, the right number at the right time. Then dosage should always be based on weight, because our regimens are weight-based. So for you to give, if you give a lower you give the wrong dose, those you end up having subtherapeutic levels, drug levels. This again will contribute to relapse because you're not going to completely clear the bacteria, and then you end up, the bacilla, then you end up having a relapse, or worse, you end up actually contributing to the development of resistance. And then we also need to have follow-up to check that we are actually having response. That is through culture and smear testing. And then also looking for clinical response. You need to see the patient is actually getting better. If after 2 months you're doing your cultures and you're still seeing they're positive, then that means that regimen is actually a failing regimen and you should change regimen. Same with if the patient, your child is not improving after 1 to 2 weeks, then you know that maybe there's an issue with the regimen you're taking, and maybe you need to investigate changing regimens. So remember I mentioned that we need to have agents that are both bactericidal and sterilizing, as you can see. So from this table, you can see the rifampicin tends to be the one that meets most of our criteria. It has good bactericidal activity, it has good sterilizing activity, and also it tends to be less toxic compared to the other medicines. And that's one of the reasons why we're also a bit hesitant about moving to TPT for using the 4 month of rifampicin for TPT because of that. This is our mainstay, and it would be very sad should this lead to development of resistance to rifampicin, we increase our cases of rifampicin resistance. Because right now, as we speak, our highest, the most resistant strains actually rifampicin, MDR-RR resistant, tends to contribute to around 60% of the current resistance within the DRTB resistant strains that we have been observing. That is from last year. So our second line drugs that we usually use for drug resistance tend to have moderate bactericidal, sterilizing, and also to have moderate toxicity. So you see, the smart thing is to ensure that we catch and treat the TB when it's still drug sensitive, when it is sensitive to all our molecules, because the more resistance we develop, the less effective the drugs we have, and the more toxic they tend to be, and the longer you tend to give them for. So having a negative feedback loop, because the longer you take, the more likely you're going to have issues with compliance, the more resistance you're going to develop. So if you're able to catch and treat TB at the drug sensitive phase, then we're more likely to actually achieve our goals of reducing effects of TB on our clients. So these are the recommended TB regimens. I think we should all know. You may not know anything else. You may not know about the drug resistance components, regimens, but as pharmacists, at least we should know. Even I knew this. When you left school, we knew that we usually use a combination therapy of rifampicin, isoniazid, pyrazinamide, and ethambutol. And this usually can be given as a fixed dose combination of the 4, or it can be given as individual tablets, but then this tends to increase the pill burden. So that is usually for the initiation phase. We usually take for 2 months for the 4 medicines. Then for the continuation phase, depending on the form of TB, you're either going to take the rifampicin, isoniazid for 4 months, for 10 months. 4 months if it is all forms of TB other than TB meningitis or post-articular TB. Then if it is TB meningitis or TB of the bone, then you're going to take the continuation phase for 10 months. And the reason is, when it's gone to the meninges, when it's gone to the bone, it takes longer. They're hiding. The granulomas are quite, you need to give it a sufficient time for the medicines to permeate into these cavities so that they're able to clear the dormant bacilli that are already, have moved to those areas. Then for children, so this is the same regimen for children, though this one now we have, depending again on the TB disease, the initiation phase is the same. You're going to take 2 months, sorry, you're going to take 2 months of the 4 drugs in the regimen, that is rifampicin, isoniazid, pyrazinamide, and ethambutol. And then depending on the form of TB, the continuation phase can be 2 months, 4 months, or 10 months. So 2 months of RH will be for those children who are between 1 and 10 years and have non-severe disease. If they are less than 1 year or they are more than 10 years and they have severe disease, then they will take the rifampicin, the normal 4 months of 4 months of rifampicin isoniazid in the continuation phase. Then the 10-month RH continuation phase is the same as for the adults. When we have the TB meningitis or osteoarticular TB, again for the same reasons, to allow for enough time for the medicines to permeate the cavities. So one of the developments the WHO that has been doing over the years is to try and move to a more patient-centric model of care. We are aware treating a patient for 6 months can tend to can take a toll on the patient, especially if the patient is coming from a low-income setting, and given the fact that as a component of direct observed therapy, they have to go pick their medicines after every 2 weeks. So they're not going to be given all the medicine and then somebody goes observe. They actually have to come and take their medicines at the TB clinic every 2 weeks. And so you can imagine if you're coming from a low-income setting, then having to go to the hospital, and if you're quite removed from the facility, then it can actually have quite a higher implication on economic implication on that individual. You might actually find that the patient is not going as they should, and this actually has an effect on compliance, again leading to relapse or resistance pattern. So part of the WHO drive has been to try and see whether we can have a reduction of the duration of treatment. And one of the studies that several studies have actually been done to see whether this can be done. And one of the studies that was done, I'll talk a bit more about this, is actually a 4-month regimen where you're taking isoniazid, rifampicin, moxifloxacin, and pyrazinamide, and you're going to take 2 months initiation phase where you're going to take the isoniazid, pyrazinamide, moxifloxacin, and pyrazinamide, and then a continuation phase of another 2 months of isoniazid, rifampicin, and moxifloxacin. And this was based on a study called Study 31 trial. I will talk more about this. And then the other one was also for pediatrics, and I think I have mentioned this in the previous slide, that another study called the SHINE trial found that for children aged between 3 months and 16 years, who have non-severe disease, actually, they are able to get positive treatment results from this. And when the Kenyan experts look at this, and they looked at this, and they recommended that instead of adopting the regimen as is from the WHO, we're actually going to adopt between our 1 and 10, instead of the 3 months to 16, only 1 and 10 years. 1 year and 10 years actually going to be the ones who are going to be eligible for this regimen. And this was rolled out. We're already doing this from 1st of January 2024. This was rolled out, and this is actually now standard regimen. And that's why in the previous slide I talked as one of the recommended regimens. So quickly, let me talk about this new, it's actually not a new recommendation. This was a recommendation from 2022 for the study 31 that is actually recommending the utilization of isoniazid, rifampicin, pyrazinamide, and moxifloxacin. So this was based on a study that was done in 13 countries with a sample size of 2,516 patients. And Kenya was one of those participating countries. And what it found that is this regimen was not was non-inferior. Rather, it was not any more different from the current 6-month regimen we're using. And it did not indicate any increase in mortality or adverse events between the two. So essentially, it could be used as a replacement. So who are eligible for this? These are children and adults, children above 12 years, and adults who are more than 40 kgs. So children above 12 years and who are more than 40 kgs, and then all adults who are more than 40 kgs. So those are the ones who are eligible for this regimen. And who have pulmonary TB, who have PTB, pulmonary TB. So exclusion, anybody patient who is more than 40 kilograms is not eligible for this regimen. Any patient who has extrapulmonary TB is not eligible for this regimen. And any patient, any PLHIV who has a CD4 count of less than 100 is also not eligible for this regimen. And then any child below 12 years is not eligible. And of course, because rifampicin is not indicated for pregnant lactating women again, so these are also excluded from this regimen. So it's essentially for adults and children who are more than children who are more than 12 years, sorry, and who are more than 40 kgs. Sorry, I confused myself there. So the duration of the regimen, I touched on that, is going to be 4 months. So you start with 2 months of initiation phase of isoniazid, rifampicin, moxifloxacin, and isoniazid, rifampicin, moxifloxacin, and pyrazinamide, and then a continuation phase of isoniazid, rifampicin, and moxifloxacin. It is just like the current regimen we're using. It's a daily dosing. So you're taking a certain number of tablets per week, per day, depending on the weight. But unlike the other regimen, the dose for rifampicin and moxifloxacin are fixed. So the rifampicin is fixed at 1200 and moxifloxacin is fixed at 400 milligrams. And we cannot replace moxi with the levo or any other fluoroquinolone. And we can, just like with the current regimen you're using, we cannot replace. We cannot expand, continue the duration of, we cannot prolong the treatment past 4 months, the recommended 4 months. So just to be clear, I'm not saying this is a new recommended regimen for TB that we are adopting as a country. It is just what the WHO has recommended. The countries right now, we are looking at it, and we will make a decision whether we are going to proceed or not. But the next slide will show you some of the challenges that the country will encounter should it decide to go with this regimen. So again, this is not a regimen that we are currently using, but as healthcare workers, as pharmacists, it's good to know, so that sometimes you may find if you have these regimens and you don't have anything else, it's something maybe you can consider. So when you compare to the current regimen that we're using, one of the biggest differences, since there's no fixed dose combination for this new regimen for isoniazid, rifampicin, moxifloxacin, and pyrazinamide, then you are going to take, the pill burden is quite high. Here you can see you're going to take 9 tablets. This is compared to the 3 that we usually take. This for a patient who's weighing between maybe 40 and 60 kgs, we usually take 3 tablets for the normal RHZD. So they are going to take an equivalent 9 tablets for the same effect. And more important is the cost. You can see the cost per dose of the existing regimen is about $33, while for this new regimen, it's going to be around $166. And the main driver for this cost is the rifampicin, because rifampicin currently is quite expensive. But there's a possibility of this coming down as more countries pick this up as a fixed dose combination is made available. Because right now I know there are quite a number of the manufacturing companies are doing R&D to actually have a fixed dose combination available. Just like we had a fixed dose combination initially when we started the 3HP for adult, we did not have a fixed dose combination for TPT, but eventually we ended up having a fixed dose that available, and that also brought down the cost of the rifampicin isoniazid for TPT. So this is also a possibility in the future, but it is good to know. So right now we are not moving to this, but it is something we are considering, and it is something also as people at the service delivery points also need to be aware of. So some of the points to remember as you're treating is monitoring of weight, especially for children. You know, children tend to gain weight very quickly. And as I said, our treatment is weight-based, so you have to keep constantly monitoring and adjusting the the doses based on the weight that to adjust the dose based on the weight of the patient during those subsequent visits from the initiation of treatment. Then all patients should be, all anti-TB patients, all clients on TB patient, and on all TB clients who are on TB therapy should take pyridoxine. But note that lack of pyridoxine is not reason to stop TB therapy. We can continue TB therapy if pyridoxine if you don't have pyridoxine. And this is mainly to reduce peripheral neuropathy that develops as a consequence of isoniazid, that is usually mainly caused by isoniazid. We'll be having one of our subsequent webinars where we'll be talking more, we'll go more into depth about the adverse events the more common adverse events expected from the regimen, from the medicines that consist our TB regimens. So I will finish up with the treatment of DRTB. So over the years, DRTB has been, Mycobacterium bacilli has been shown to actually develop spontaneous mutations over the years. So, and some of these mutations tend to affect some of the genes that are targeted. And some of the genes that express the enzymes, the cell wall that are actually targeted by the TB drugs. And this leads to development of resistance to our current regimens of TB. And as you've seen, our pool of TB medicines are not that many. And if you look at the history of the TB medicines, most of the four regimens I mentioned, the four components of the standard regimen that we've been using over the years, most of these were discovered between 1950s and the 1960s. The next newer drug that was developed specifically for TB was bedaquiline. This was in 2012, then followed by delamandid in 2013, and the current pretonamid we're using in 2019. You can see that big gap in terms of research and availability of medicines. There is research into new medicines, but we do not have that many drugs available specifically for management of TB. And most tend to be repurposed medicines. And the challenge with repurposed medicines, they're also being used for other conditions out there. And remember, there's that 23,000 number that is being undetected. So if you treat that with a monotherapy of maybe amoxifloxacin or levofloxacin, you end up you are leading to the possibility of developing resistance. So the repurposed medicines, as much as they are effective right now, there's a danger to resistance being used, since they are not specific, they're not just being used for treatment management of TB. The drugs that are being used for management of TB specifically are very few. So you need to safeguard them to ensure that we do not develop resistance. That can only be done through the combination therapy and also doing active DST, so that we ensure that the medicines we're giving actually are the mycobacterium we are treating are susceptible to the medicines that you're giving. So I mentioned that we'll have spent, how resistance develops. The first one, as I mentioned, is for the mycobacterium, it's mentioned it actually has spontaneous. We actually have spontaneous mutation. So a patient may actually have may actually contract a mycobacterium strain that is already resistant through the spontaneous mutations that is already resistant to the first-line TB medicines. Then that is secondary resistance DRTB. We also can have secondary resistance DRTB, and this is where a patient who has been infected, who has been exposed to a drug susceptible TB will develop resistance during treatment, either through that spontaneous mutation, so rendering the mycobacterium that they infected with actually resistant to the first-line medicines. Then there's amplified DRTB resistance, and this is a worsening of the resistance. So essentially, the patient has already been affected by the drug-resistant TB, either through primary or secondary resistance, and then either due to incorrect medication or inappropriate dosages, you end up developing further resistance. So initially, maybe you are resistant to rifampicin, but then because of being given inadequate or the wrong formulation, you end up also being resistant to isoniazid. So this is just a depiction of the same. So assuming the patient is infected by a bacillus that is resistant to isoniazid, as majority of the bacilli, as you know, in the normal distribution, then the majority will actually be susceptible, but we'll have a small population that will be resistant through spontaneous mutations that will be resistant to isoniazid, rifampicin, and pyrazinamide. So if you treat that patient with just isoniazid, this is the case why you should not actually do monotherapy, then you will clear out all the bacilli other than the ones that are the small population that are resistant to isoniazid. But initially, since you've cleared all the other population, then suddenly now your population will just consist of isoniazid resistant strains. And that is that's why now you actually end up getting secondary DRTB infection to isoniazid. And how will amplification happen? So assuming that same patient has spontaneous, now the isoniazid resistant strain actually has spontaneous mutations that lead to now having resistance to pyrazinamide and rifampicin. Again, if we are treating now, with this case, now we treat this same patient now, continuation phase, we are treating them with isoniazid and rifampicin. Remember, most of these strains are already resistant to isoniazid. So the rifampicin will clear all the isoniazid resistant strains since they are still susceptible to the rifampicin. But unfortunately, it will not clear the isoniazid resistant strains that spontaneously mutated to become also resistant to rifampicin. So what happens now? You have amplified. You started with drug sensitive. You got because of incorrect regimens. You got isoniazid resistant strains being the majority of your inoculum. Then, since again, because now you are not aware and you moved over to the continuation phase, you end up now actually selecting for the isoniazid rifampicin resistant strains. Essentially, you've amplified your resistance. So, and that is why at the initial phase I mentioned, drug sensitivity is very key, and combination therapy of 4 molecules is very key, so that you ensure that at even now, like assuming this case, when we're having when you have the spontaneous mutations to rifampicin and isoniazid, if you had a regimen consisting of maybe of pyrazinamide and ethambutol, then they would have cleared the isoniazid, the resistant strains, and also would have cleared the isoniazid rifampicin resistant strains. And that forms the basis of why you do a combination therapy. Okay, so what are the risk factors associated with DRTB? They can be healthcare provider related, it can be drug related, it can be patient related. For healthcare provider related problems is actually could be partly we don't have guidelines, so the healthcare workers do not know what to do, or there are guidelines, but the healthcare workers do not follow those guidelines, or there are guidelines and they're not properly trained. So in essence, again, you are still not following, they're not doing the right thing based on what should be done. The other one is if you're not monitoring the treatment carefully. Remember, you have to monitor, you have to see whether the patient is, the smear cultures are actually converting, or whether the patient is actually taking the medicine as they should be taking. And then, very important, if the program that manages TB is poorly organized, or if it is not properly funded, of course, then the guidelines will not be developed, or the people will not be trained, the healthcare workers will not be trained, and the treatment monitoring will not be implemented or followed up. So all these contribute to developing drug resistance. For drug-related factors, we have inadequate supply of the drug. So if you have erratic, as I said, the regimen is 6 months. If you get drugs for 1 month, then you take 2 months before you get for the next 2 months. And of course, then you're going to have subtherapeutic drug levels the patient, and this can lead to development of resistance. If you have poor quality medicines, if the medicines are not stored well, leading to degradation. If you give the wrong dose or the wrong combination, what regulation this has to do with the poor quality of medicines. And then for the patient factors, if the patient is not adhering to the medicine that they should, they're not taking them for the period they should be taking, or for the duration at the frequency they should be taking, if they don't have the correct information, and then lack of transport. I mentioned for those who come from low-income areas who are not able to go to the facility at the time that they should be going, then again, that also contributes to them not getting the medicines the time they should be getting. We have adverse events that will lead to the patients refusing to take the medicines. Then you have social barriers. Those people who are stigmatized, they do not want to be seen they are taking medicines. So the forms of drug resistance that we have monoresistant TB. This is a TB isolate that is resistant to any of the first-line drugs, isoniazid, rifampicin, parazinamide, and ethambutol. Then we have rifampicin-resistant TB strains. So this is still mono, but now it's specifically resistant to rifampicin. Then we have multi-drug resistant TB. This is one that is resistant to both isoniazid and rifampicin. Then we have polydrug resistant TB, and this is a strain that is resistant to any of the first line other than isoniazid and rifampicin. Essentially, if it is resistant to more than one of, essentially by a law of elimination, any strain that is resistant to parazinamide and ethambutol will be classified as a polydrug resistant strain. I mentioned the majority of our cases are MDR, RR, that is multi-drug resistant or rifampicin resistant strains, and monoresistant, specifically isoniazid monoresistant. These usually account to close to over 90% of the DRTB cases in the country over the years. So PR polydrug resistant consists of a very small percentage, around 1%. Then we have pre-XDR, that is pre-extensive drug resistant TB. And so this is a TB that TB isolate that is resistant to rifampicin, isoniazid. In addition, it is also resistant to fluoroquinolone. So that's what we call pre-XDR. Then XDR, that is extensive drug resistant TB, is one that is resistant to rifampicin, isoniazid, to fluoroquinolone, and then additionally group A drug. I'll show you what the group A drugs are. These are the bedaquiline, linezolid. Yeah, so that group A drug, that now constitutes XDR TB. And you'll see in the next slide, or I think the next two slides. Essentially, this is a patient who's resistant to all the drugs that are our mainstay in management of DRTB. And this is a case that we usually try to avoid as much as possible. We usually have, like now, we usually project 0.1%. Like essentially, that's one case. Last year, luckily, we do not have any case, but the previous year and the year before that, we actually had one case each year in 2022 and 2023. They're usually very difficult and very expensive to treat. And another thing, as the resistant part, as you become more resistant to more of the first-line drug medicines, the more expensive the treatment is for that particular for treatment. So the principles we have to individually. So for the XDR patient, we actually have to do an individualized regimen. And how do we do that? We actually ensure that if you have any new medicines, that becomes the first candidate for development of that regimen. Then that the next drug that the next principle is whatever drug we're choosing has to show some activity against MDR and XDR. And then we need to at least have 3 to 5 effective medicines. Preferably, they should be taken in orally. We should have a simple dosing schedule. This is not always possible. It is an ideal that we are never usually able to meet. Same with number 6, having a good side effect profile. And then also to try and minimize the length of treatment. Again, this is it's an ideal that we try to balance, but usually tends to take much longer than we would have preferred. And then to get drugs that have minimal drug-to-drug interactions. So using those principles, I think we've changed over the years, we've changed our regimens. I can give an example specifically for MDR, RR. So initially between 2006 and 2017, we used to treat this for 20 months. And one of the regimens used to be an injectable kanamycin. Can you imagine being injected with kanamycin for 20 months? This without even excluding the expected ototoxicity that is known from the glycosides, kanamycin. This moved to a shorter injectable regimen for 9 to 11 months. Using that same principle, then we moved to the 18 to 20 months in 2020. Finally, to the 6-month regimen, where for that we rolled out last year, where we are trying to minimize. You have newer drugs, you got a newer drug, we're able to combine newer drugs and repurpose drugs to have a reduction in the treatment duration. So these are the the groupings of the drugs. So group A consists of levo, fluoroquinolone, either levo or moxi, fluoxetine, bedaquiline, and linezolid. So when you are constituting a regimen, if the isolates show susceptibility to these three drugs, these are all included in that individualized regimen. Then for group B, this contains clofazimine and cycloserine. These are always added unless there's an issue that there's some resistance, the patient is not able to tolerate them. Then group C that are usually included to complete the regimen. You see, I mentioned that you're treating from you need a regimen of 3 to 5 drugs. So if you're not able to get the full 5 from the first group A and B, then you use group C to complete your regimen. Okay. So I'm almost done. I'm going to quickly take you through the regimens, the recommended regimens for treatment of the resistance patterns that I mentioned. So isoniazid monoresistance, we usually just we add levofloxacin, because from this regimen, from the recommended regimen of rifampicin, isoniazid, parazinamide, and ethambutol, the drug is only resistant to one of the 4 components, that is isoniazid. So what we do, we'll add levofloxacin, and then we give that regimen for 6 months. Remember, the normal is 2 months of the 4, then you move to 4 months of the rifampicin isoniazid. But in this case, since we have resistance to isoniazid and to avoid monotherapy, we add levofloxacin, and then they take the complete 4 regimens. Now 5 drugs for 6 months. That is for both adult and children. For polydrug resistance, same. They continue. We just add levofloxacin to the regimen, because again, in as much as they are resistant to pyrazinamide, ethambutol, they are still sensitive. That isolate is sensitive to rifampicin isoniazid. So they're actually taking sensitive to 3 of the 5 components that they're taking. So again, so this is what we give, and they take this for 9 months. Again, it's both adult and children. For children, it's usually child-friendly regimens. Then for MDR-RR, I mentioned this, we have a new regimen that was launched last year that consists of bedaquiline, pretonamide. Pretonamide is one of the newer, the most current drug that has been registered for use in treatment of TB. It was specifically developed for the management of TB by the TB Alliance. It was registered in the USA in 2019. So this was used to develop a new regimen that contains bedaquiline, pretonamide, linezolid, and amoxifloxacin, and this replaced the previous 18-month regimen. So this is taken for 6 months. That is for non-severe disease. Unfortunately, for the severe disease, they have to take an 18-month regimen. This was the previous regimen that even the non-severe disease used to take. And this consists of 6 months of bedaquiline, levofloxacin, linezolid, cycloserine, and clofazimine. That is the initiation phase, and then a continuation phase of 12 months of levofloxacin, cycloserine, and clofazimine. For children, unfortunately, BPAM is not recommended for children. So we have a regimen, a very complicated regimen that is usually 9 to 11 months. So it consists of, you're going to take 2 months of bedaquiline, linezolid, levofloxacin, clofazimine, pyrazinamide, ethambutol on high dose, isoniazid. Then after 2 months, you're going to drop linezolid and then continue with bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, and isoniazid. And you're going to continue with this regimen either for 2 months to 4 months, depending on whether you're going on whether the culture, the sputum culture that you've been monitoring, whether it converts from positive to negative. So it is negative after 2 months, you're going to stop. If after 2 months it has not stopped, you're going to continue for another 2 months. That is why it's 2 to 4 months. And then that becomes now the initiation phase. Then depending on whether you finished at 2 or 4 months, then you have a continuation phase of 5 months of levofloxacin, levofloxacin, clofazimine, pyrazinamide, and ethambutol. So that's why I mentioned this is a regimen of 9 to 11 months. So 9 if they convert after 2 months, or 4 months, sorry, 11 months if they convert after 4 months. Then for children, severe disease, they take a regimen that is similar to the adults, but now child-friendly for 18 months. Then for pre-XDR, this is a patient now who's, remember, they are resistant to isoniazid, isoniazid, rifampicin, and fluoroquinolone. So we cannot have fluoroquinolone in that regimen. So for children, non-severe, going to take a 9-month regimen that consists of bedaquiline, initiation phase of 6 months of bedaquiline, delamanid, linezolid, cycloserine, and clofazimine. Then you have a continuation phase of delamanid, cycloserine, and clofazimine. For adults, the same regimen, the BPAM regimen I mentioned that contains bedaquiline, pretonamide, and linezolid. But since now this the isolate is resistant to moxifloxacin, we drop moxifloxacin and we give this regimen for 9 months. So we are hoping that future studies will actually show that this regimen can also, both this and the BPAM regimen, the full BPAM regimen can also be used in children, because that would really end up reducing the duration of our treatment. Then for severe disease, take a regimen that consists of bedaquiline, delamanid, linezolid, cycloserine, and clofazimine. That is for 6 months initiation phase, and a continuation phase for 18 months, sorry, for 12 months, consisting of delamanid, cycloserine, and clofazimine. For XDR, we individualize the regimen based on the criteria that I presented in the last, second last and last slides. So even the duration is also individualized, but most of the time it will be 18 to 20 months. It will not be short. I think that is my last slide. Thank you, and thank you so much for your attention, and thank you for the time. I know I've gone slightly above time, but I hope I've been informative. Thank you so much.
All right, thank you so much, Dr. Ernest, for sharing that presentation. I see we've gone a bit over time, but I think we'll be able to answer a few questions before we close the session. But I think it's been very informative, and I think for many of us as well, it's been a refresher on management of TB. So I think maybe we can have 3 questions. Then after the session, I could maybe share some of the other questions that can respond. Then when sharing the recording with our members, they can get the feedback on some of the questions that have been brought up. So I think we'll start with the first question here, which is with regards to integration of TB management in health facilities. Does it cause public health danger when we have patients being managed in the facilities with all the other patients? Maybe you can comment with that on that, as well as the reason why we have 57% incidence in men and 30% in women. Why there's a huge difference?
Okay, for the integration, the purpose is not to say that the patient, actually, the reason of the purpose for the integration is actually to prevent transmission. So that, for example, if it's a diabetic patient, they will be treated at the TB clinic. We are not just going to say this is I'll only treat, since this is I'll only treat TB, then I send that patient, I'll go back to the diabetic clinic to be managed. Rather, no, since we know that there is a risk of that patient infecting other patients, so they are going to be treated wholesomely in that in an environment where they will not be able to infect the others, to infect other patients. Same thing like that happens with the HIV, because the HIV, the CCC, it's actually it's quite integrated these days in most of the facilities. So you find that the CCC clinic and the TB clinic are actually integrated in the same place, so that the patient is being seen at the same place, in the same, meeting the same infection prevention control measures to ensure that they do not spread the TB to other patients. So they are seen in an environment that is safe for them, the healthcare worker, and the other patients. So that is what integration is all about. Not that the TB patient will go to the diabetic clinic or the cancer clinic and be treated there. Rather, they will be treated at the TB clinic wholesomely so that all their issues are managed in one place. Thank you. In terms of why it is high in men, that one I am not there are some studies that have been done. I've not yet been able to ascertain, because it's also a question I've asked myself, because when I look, and it's actually something that happens constantly. So it is something that is some studies have been done to try and figure out why that is the case. Thank you.
All right, thanks for that. There's another question from Dr. Massey, who says fluoroquinolone resistance in MTB is a growing concern, particularly in the context of MDR TB and extensively drug resistance TB. Considering that there are crucial second-line drugs for treating drug resistance TB, but resistance to these drugs is increasingly reported, leading to poorer treatment outcomes and potentially contributing to the spread of extensively drug-resistant TB. What will be our saving grace?
Sorry, I think number one is on our side for TB, it's actually having mentioned that you have to do drug sensitivity, second-line drug sensitivity testing before you actually put that patient on that on a fluoroquinolone regimen. Fluoroquinolone a regimen that consists of fluoroquinolone, to ensure that you do not make the situation worse by giving a patient a drug that they're already resistant to. And that is something that as a program we are constantly doing. We actually, before, especially for our DRTB patient, we're actually doing drug sensitivity, second line, whether genotypic or phenotypic drug sensitivity testing, to ensure that we do not exacerbate the situation. The other one is more of a general, actually more of a public health issue. And I think part of it is probably prudent antibiotic usage. It's not just fluoroquinolone, actually. We know we're having a high level of antibiotic resistance. So it's probably having better stewardship of antibiotics through training, through sensitization, through awareness of the healthcare workers and also the general public on the dangers of imprudent use of our antibiotics.
Right. Thank you for that, Dr. And I think the last two questions that we'll take is one is with regards to the current stockouts of anti-TBs, and when should the healthcare workers expect steady supply. And I think the last one will be on malnutrition, which is one of the challenges that is hindering positive outcomes. And currently, do you have any programs that are focused on tackling the issue of malnutrition? Maybe you can address the two, then I think the rest of the questions we'll see how to send over.
Okay, so with regard to the stockouts of anti-TB, so I think the program has been actively working towards ensuring that we have adequate commodities. Currently, at national level, we do have adequate commodities. I know we have been having some challenges in getting commodities to some of the sub-county, some of the facilities, some of the service delivery points. This is not a generalized problem. It's a point problem in specific facilities. So as a program, we've actually been taking steps to try and figure out, do a deep dive, root cause analysis, and try and figure out why we are having some artificial, because I'll call it artificial stockouts at those specific service delivery points. Well, at national level, we do have adequate commodities. So we are hoping that part of this process, because we are looking not just at it's an open process. We are looking at our own systems at the program, also looking at the systems at the county, at the sub-county, and at the facility level to figure out at what point are we getting that disconnect, that breakdown in that time, the communication in the commodities, and then hopefully come up with proper interventions that will ensure that the situation at national level translates to the situation at the service delivery points. But right now, at national level, we have adequate commodity. We are not stocked out for any of our commodities. Thank you. With regard to the malnutrition, probably I'm not, I will probably not have the adequate information to fully answer this for the malnutrition, but I do agree malnutrition is a big problem because our TB patients tend to be malnourished, and I know we've also been stocked out of our nutrition commodities. We've been trying to look for funding to try and get funding to procure nutrition commodities. But that is an ongoing problem, and that's an ongoing issue that the program is also working towards addressing and solving. Thank you.
All right. Thank you so much, Dr. Mbai. I see we still have a couple of questions that we have, but I think what we'll do is consolidate them and then send them over so that you can maybe have a look at them, and then we'll be able to share with our members when circulating the recording. And also, I know that this is going to be a series of webinar, and we'll be able to maybe tackle some of these questions in the coming webinars. So I think at this point we'll end the session. I'd like to thank you again. Thank you for sharing the insights on management of TB, and we look forward to engaging in more sessions. And for the supporters of this session, MSH, Tamatisha TB, thank you so much. And Ministry of Health, the National Tuberculosis, Leprosy and Lung Disease Program, thank you so much for the support. Dr. Joseph Mukoko from MSH, thank you for the support, and the entire MSH team. For our members, thank you as well for joining this session, and we look forward to having you in the next series of webinars. So at this point, we'll end the webinar, and have a good night.
Thank you.
Thank you all. Thank you for your attendance and your active participation. Thank you. Have a good night, all of you.
You too. Thank you.